as we see it in many cases in some of the patients. So I'll move on to the second point, which is the post-operative atrial fibrillation for atrial fibrillation in particular. So this is use of anticoagulation for patients who develop atrial fibrillation in the intensive care unit, whether post-operatively or non-post-operatively. This is, I have to make it clear, this is for non-valvular atrial fibrillation, because the newer generation of oral anticoagulant, which is called the NOACs, or the novel, or if you want to call them the non-VKA oral anticoagulant, is meant in particularly for the management of non-valvular AF. These drugs coming into our daily practice very fast, and I think all physicians and intensivists, internists have to deal with them and has to be familiar with their mechanism of action and how to adjust the doses based on many factors, age, renal function, and also in case of patients have bleeding, how to deal with them in regard to management, general supportive measures, and even lately how to use some of the antidotes start to be introduced to the market in reversing the effect of these anticoagulants. This group of a drug is actually taking over the use of Coumadin or warfarin that has been classically used in non-valvular AF. The beauty of them, they are having fast onset and fast offset. They are usually therapeutic within hours of oral administration, and the effect usually goes away after 24 hours. This is the setup where most of our anesthesia colleagues in regard to procedure want to achieve. They don't like the warfarin, which take longer time to disappear from the circulation, and to start them again, they need 3 to 4 days to build up and to be bridged with parenteral anticoagulant. And usually they have a wide therapeutic window, not like warfarin. If you go high in INR or low in INR, you lose therapeutic effect or you have a higher risk of bleeding. Usually they are administered once or twice daily, and they have also the least drug-to-drug interaction, as also least food-to-drug interaction, which is commonly encountered in Coumadin. And of course, the only limitation is the antidote in case of we having a major bleeding, and I think this issue is gradually being sorted out slowly with the current available antidotes. Okay, mechanism of action, they are either a direct 10A factor inhibition like the rivaroxaban and apixaban, or the dabigatran, which is inhibit the factor 2, which is a direct thrombin inhibitor. I move on to the second or the third part of new-onset atrial fibrillation termination. Means how to cardivert the patient when the patient develops a new-onset AF or occurrence of atrial fibrillation, and how to go back to sinus rhythm. I truly believe, and I'm a big advocate in my laboratory and in my hospital of electrical cardioversion. It is safe, clean, and very effective, and very cheap. And usually, if you use it properly, you're not going to see any complication. I would say 0 complication, because it is really wonderful thing to achieve sinus rhythm in atrial fibrillation. The only limitation of it is, of course, it needs sedation, not necessarily deep sedation, maybe conscious sedation. If it is probably the patient is fasting for 2 to 3 hours, he should be ready for the procedure. But in case if we don't want to do it, like most of the cases, because we don't want to do it, but in some cases we cannot do it, then you can use some drugs. And believe me, there is no such a drug now in the market that can get close in the success rate to electrical cardioversion. The one that is banned out and still we are using is intravenous amiodarone. It is not bad, but it is not great. Success rate in cardioversion can reach up to 65%, not much higher than spontaneous rate of cardioversion. Spontaneous rate of new-onset cardioversion is around 50%. Amiodarone makes it up to 65%, maybe 70%. Then we have some other fancy drug, like IV flecainide. Exclusively, we use it in the pediatric ICUs. And there are some newer drugs, like IV ibutilide, and also there is one very new one. It's called IV vernicalent or Brinavis. It's approved in Europe. There is some big debate in the United States how whether to approve it or not to approve it, FDA back and forth. But I think it has some good effect. It's almost as effective as Cordarone in terminating a new-onset atrial fibrillation. The advantage over Cordarone, it can achieve that within minutes rather than waiting 4 hours. So if you give 2 milligrams of IV vernicalent, there is a good chance to achieve sinus rhythm in maybe half an hour. And if you are in an emergency setup, patient can go home. If you are in the ICU, then you are way to go without using electrical cardioversion. So the efficacy of a vernicalent is reasonable. So I have 2 minutes. I will just go over the last topic, which is device and management of patient with device and regarding to anesthesia, in particular to electrocautery and the electromagnetic interference. That is the daily challenge we are encounter in regard of these patients. And whether to take them to the OR, whether need to program their devices, whether need to switch off this thing, whether we need to program them to asynchronous mode. Basically, our pacemaker nowadays, they coordinate their activity with the heart activities. So they sense, they see what is going inside the heart, and then they act, whether they pace, or if they see too much activity, they fibrillate, or they defibrillate. So this can be mimicked by the electrocautery, because electrocautery, as you know, is an RF energy that travels through the body from the tip of the bovie pin to the exit point, which is the pad we attach to the patient body. So this can get into the circuit and interpreted by the device as an intrinsic event or as a VT, and then start to behave stupidly and wrongly to what we see. So the pacemaker, which we see today in most of our patients, should be precisely identified by our anesthetist. Is this a patient with a pacemaker or is this a defibrillator? And this is very crucial. This can be done bedside or by the chest X-ray without calling the cardiologist or the intensivist, because that can save you a trip and save the patient a trip to the pacemaker clinic or even to the other hospital if you don't have a pacemaker clinic. So this is the old pacemaker. This is the pacemaker before Dr. Shamsa was born. This is a huge machine. But if you look at the other chest X-ray, this is a very important X-ray. I always like to throw this X-ray for my colleague to identify the scope of devices we are seeing. This is a chest X-ray of a patient with biventricular ICD. This is a very important X-ray, because if you look at this X-ray, this is not a pacemaker. This is a defibrillator. Why? Because you can see in the RV lead there is a coil. That coil makes you identify that this is an AICD. So this is a very important step. Then you can see the lead. There are 3 leads here, one in the right atrium, one on the right ventricle, and then one posterior to the LV going through the coronary sinus, which pays the left ventricle. This is a very important X-ray for the junior colleague of any department to be able to identify from the X-ray whether this is a pacemaker or an ICD. Okay, so EMI, electromechanical interference, can come from inside the heart for the anesthetists. They don't care about it, like insulation, a break of the lead, or myopotential, which is happening rarely because nowadays we have more smart lead, bipolar. They can pick up things only from inside the heart. But for the anesthesia department and for the anesthetist, there are many sources. The main one, of course, is the electrocautery, but other things can interfere and can cause electromechanical interference, such as some ventilators. Some patient might go to an MRI for a test to have evaluation. Some anesthetists, maybe they leave their cell phone beside the patient, and the cell phone, some of them, they have a range of interference, lithotripsy, TENS, TERPs, neuromodulation. Doctor is here for questions whether these things can interfere or they don't interfere. I think You have to understand now, our pacemakers, they have great sensing capability, and they can identify cleverly to a good probability, this is an intrinsic rhythm or this is an artifact or noise getting into the circulation, because I said there is a bipolar sensing configuration in the tip of the lead. The generator becoming more shielded, and there are filtering mechanism that can think this is very high frequency, cannot be just a simple arrhythmia or intrinsic pacing rhythm, so the device will ignore it, or at least it can do some safety measures to maintain pacing or to stop the fibrillation if it is in AICD. But in general, that what happen if you bovie the patient if they have a devices. There will be an electrical event or electrical activity. They go through the circuit, through the patient body as a conductor, and if it is a pacemaker, it can create an inhibition to the pacemaker and can cause pauses, and if the patient is a pacemaker dependent, then you will have actually asystole during the time of bovieing. And this happened only during the time of the bovieing. And this is a very important point, because most of the surgeons, when they start to use the cautery, they don't go very long, and they usually stop in between. So if you cause asystole, the asystole will be the duration of the time of electric cauterization. For the ICD will see this electrical activity going on, but as far as it is interrupted, then it will recount again. So the ICD needs at least counting for 10 or 15 seconds of arrhythmia in order to start think about giving a shock. This is an example of a device. It's an ICD interrogation paper where the bovieing went on for a long time. Probably they were using a cutting device, not coagulation. And they kept going on, and the device was not turned off. And in that case, the device thought, well, this must be a VF, then I have to give a shock. So it actually gave a shock. But in the EP, in our clinic, we look at it, we said, this is not a VF, cannot be VF. This is a very high frequency activity. This must be an artifact. And when we time it, we asked the patient, he said, yeah, I went for surgery at that time. And so I think when you use cutting, then cutting for sure we need to program. When you deal with a patient who is a pacemaker dependent, you look at his ECG, there is always a pacing rhythm, and you think you're gonna use cutting, then it's better to send the patient for a program. But if you're gonna have a patient going just for coagulation, intermittent coagulation, I think it's relatively safe to go to the OR without the need to call us. And there is only one exception, is bovieing around the device. I think if you're gonna bovie around the device around 10 to 15 centimeter, you better contact us, because there is a chance that there is a direct damage to the circuit of the device, and that could be a problem, because this group of patients, we have to interrogate them before the surgery, maybe after the surgery right away, and in some cases even we might need to put a temporary pacemaker in addition to our programming. I will stop here, and thank you very much if you have any questions.
Thank you very much, Dr. Ali, for the nice presentation. I'm sure the audience are happy to hear all your points and tips regarding all the questions that we ask ourselves every day, and maybe sometime we panic for no reason.
Actually, after that I was chair at Ottawa. So the Heart Institute was actually very much a part of our practice. When my previous speaker was talking about the amiodarone, I just remember a case where it was one of my patients. I dropped off in the post-anesthesia care unit, and then there was a emergent stroke code. So I went downstairs, so I was not available because of the stroke code, and then the resident was called because was previously a rapid heart rate, and then they thought it was an atrial fib, and they gave amiodarone IV. By the time I came back, the patient was in pre-arrest state. I was very concerned, and we ended up giving Muranone, starting in an art line, support the circulation. So I really second the statement made amiodarone IV, really have to be careful how you use it. We use it. We definitely use it, both in open hearts, after pump run, and in vascular room, but sometimes it's very dramatic. I was the PI for the POISE, and I guess that's one of the reasons why I'm asked to talk about beta blockers. If you have a patient who has some history of angina coming for elective non-cardiac surgery, I like to see in the audience how many of you would start a beta blocker if the patient is not on beta blocker right now. Oh, nobody? Oh, okay. Okay. Pass the buck. Okay. Oh, thank you. All right. So I'm going to go a little bit through the history of the beta blockers, and then try and focus on what is it that we truly know about, and then try to talk about what are the cautions around the use of perioperative beta blockers. So the whole crux of this is really the perioperative use of beta blockers. You probably have not seen this, although it was very much in the cardiology literature in 2003, and this was by Grayburn and Hales, and essentially what they said was if the patient has one or two risk variables, we would start the beta blocker. And if the patient has 3 or 4 more variables, we would start the beta blockers. And Grayburn and Hales at that point actually even advocated in 2003, forget about investigating the patients prior to elective non-cardiac surgery, just start them on beta blockers. So that was one school of thought in 2003, and then this was in 2012 when Forbes magazine picked up Medicine or Mass Murder, guideline based on discredited research may have caused 800,000 deaths in Europe over the last 5 years. That was the beta blocker guidelines that came out by the European Heart Association, and that really was the result of this individual, Dr. Podermans, who basically has been fired and left Erasmus University in Holland. And one of his key papers was looking at the use of beta blockers, and he had 130 patients, and he was able to show that beta blockers reduced the peri-op MI and mortality to 3.4% from 34%. And at that time, all of us were surprised at the high event rate, but we just thought, well, maybe that's the way things are in Holland. Since then, it was found that the data fraud was the major concern in his research, and he was fired, as I said, from Erasmus. Many of his papers, unfortunately, are still in the literature. They have not been retracted. But if you look at the ACC-AHA guidelines that I referred to yesterday, there was a very explicit statement that anything to do with Poderman's research, if it was relevant, they would not mention his name. If you actually look at it, they state it very, very clearly. That's how they approach Poderman's research. And a lot of his research they actually ignored. This is from Ego and Chopra, basically looking at looking at the beta blocker guidelines, and essentially they felt that it was a mess. They didn't know what to do with it right after Poderman's discredited research. So what I'm going to try and do is give you some, I guess, certainty as to what we do know. As I said, I was the principal investigator for POISE, and it was a multidisciplinary team, and the initial grant for the CIHR, I was the principal investigator. This is what we found. We found that the use of beta blockers did reduce primary outcomes, and they were defined as cardiac death, cardiac arrest, and myocardial infarction. We also found that non-fatal MI was reduced. So we know that the beta blockers did work for those instances. The trouble was that it increased mortality, all-cause mortality. And I haven't included here, we also found that it increased stroke rate. And with that, there was a lot of caution from our Lancet paper to say, if you want to use beta blockers, really have to think that through. The data out there also is not supportive of beta blockers for low-risk patients coming for elective non-cardiac surgery. And this is just one of the papers, Lindenauer in the New England Journal. And what they did was they looked at over 600,000 patients, and of those looked at in a database, doing a propensity matching to see what happens to patients who were various risk classifications. And what they found was, if you were low risk, you actually, in their database, had an increased risk of having events. And if you look at the graph at the bottom, when you have revised cardiac risk index, RCRI greater than 4, in their database, you did save the patient's mortality. Just so to give you a little bit of a perspective on risk and mortality, the perioperative mortality in their database, when they published it, about 500,000 of those patients did not qualify for beta blockers, so they did not receive beta blockers. And of those, you can see 1.98% mortality. Now, most of us would immediately say, yeah, most of those would be in the high-risk patients. Well, if you actually look at the absolute number of mortality, and I think I've made this point in this conference before, you actually look at the absolute number of mortality, more of them are in the low-risk group. And that is simply because the denominator is that much bigger. And we tend to ignore the low-risk group, and we focus on the high-risk group. But the low-risk group actually, in absolute number, in terms of disease burden, ends up with more of the mortality. And we did also a chart review, case control, and we found the same thing. You can see RCI class 1 and class 2 with the periop MI was much higher than class 3 and class 4 in terms of absolute numbers. So low risk, there is no real indication for beta blockers. Beta blockers in emergency surgery, one of the challenges we have is very few studies looked at emergency surgery and the use of beta blockers. This is one study and one of the very few studies which attempted to look at that, but they only had 38 patients who completed the study, and really whatever conclusion one might draw from that, it was very, questionable. In our POISE study, we did actually look at 3,400 roughly of vascular patients, and we also looked at about 10% of our patients, of the 8,000 patients having emergency surgery. So in a sense, we did have a reasonable cohort of emergency surgery. And this was presented at the Canadian Anesthesia meeting as an abstract. If you look at CVC, which stands for cardiovascular complications, by surgery, urgency, and treatment assignment, if you look at, there are 4 trends, there are 4 survival curves. The top line is elective surgery receiving placebo in terms of mortality, in terms of cardiovascular complications. And the second line is, I got it mixed up, sorry. The top line is the elective surgery receiving metoprolol. The second line is the elective surgery receiving placebo. So you could see that in the survival curve, the metoprolol group did much better than the placebo group. The bottom two lines, the green line is the emergency surgery receiving placebo and emergency surgery receiving metoprolol. And if you actually look at two survival curve, there is some separation, but the separation is not that dramatic. What does that mean? Well, in that analysis, we did not find, using the POISE data, that in emergency surgery giving beta blockers gave that much of a protection, certainly much less than what we saw with the elective surgical patients. And what is interesting is, if you look at the mortality by surgical urgency and treatment assignment, and you can see again the two lines for the elective surgery for mortality, they were not that different. But if you look at emergency surgery plus placebo, their survival curve was much better than the emergency surgery receiving metoprolol. And in real life, I certainly have seen cases where patients come for emergency surgery for whatever reason, whether it's sepsis or whether it is hypovolemia or whether it is actually acute MI. Before treating the actual underlying cause, the patient was then treated with metoprolol in the ICU in order to slow the heart rate. And as soon as they did that, the wheels come off. We've seen that. And part of the reason is the heart rate actually was a compensatory mechanism to whatever was going on underlying the pathology. And we unless we treat the underlying cause, metoprolol treatment was just a symptomatic treatment and possibly taking away the compensatory mechanism that the body has mounted to protect itself. So we don't have much better data, unfortunately, at this point, but certainly in my own practice, and I would strongly suggest that before you give beta blockers in the emergency case, really figure out what is going on underlying. Beta blocker withdrawal and anemia, that we have reasonable data to say that one should be cautious about. This was published in Anesthesiology, and it was we were using our data warehouse, and what we found was that out of the 5,000 patients in our data warehouse, we looked at if the patient had perioperative MI in patients receiving beta blockers and continued during surgery or until post-op day 7, group 2 beta blockers, but discontinued during the stay, and group 3 no beta blockers. And if you look at the POMI, the post-op myocardial infarction rate, it was 1% in group 1, 7.9% in group 2, and about 0.8% in group 3. So that really piqued our curiosity. And then we went on to try and analyze in terms of stratifying the hemoglobin in those groups. So when you have a patient who is not anemic and you have beta blocker withdrawal or beta blocker continued, there wasn't much of a difference. So if you look at the graph, this would be at the far end in the corner at the back. However, if the patient is anemic, you all of a sudden will see the spike way back at the back in this three-dimensional graph, and that's when we see the profound effect of anemia in the presence of beta blocker withdrawal. So the moral of the lesson here is if someone is on beta blocker, please make sure they do continue with the beta blockers. Now, most of us will say, well, of course they get it on the ward. If you actually go and review the chart, I haven't included the data, there's a fairly high percentage. It's not like 0, it's definitely not like 100%, but certainly somewhere between 10 to 20% of patients going on the wards, not infrequently, they end up missing beta blocker dosages, whether it's for the entire duration or for a few days in the acute post-op phase. Oftentimes it's because errors of omission. People in transcribing orders just sort of stop the beta blockers until several days later and just go, oh, maybe we should restart the beta blockers. You'll be surprised how frequently it actually does occur. So to re-emphasize the point is post-hoc hemoglobin in anemia associated with beta blocker withdrawal, we definitely see an increase in peri-op MI. It was a study looking at anemia, and essentially what they found was when patients receiving more transfusions, which most likely because they were more anemic, there was a higher incidence of complications, but if they continued the beta blockers, they felt that there was protective effect. Nevertheless, what we are confirming is from the POISE data as well, we were seeing significant bleeding, significant post-op hypotension. Those are the times we may have more problems. So, in summary, peri-op prophylactic beta blockers, we definitely know that it can reduce MI, it can reduce cardiac death and cardiac arrest, but it can increase overall mortality. The protective effect is stronger in high-risk patients, and relative contraindication in our minds in patients with recent or previous CVA, and low-risk patients may not benefit from the perioperative beta blockers. And in emergency cases, we really suggest that you need to figure out what the underlying mechanism is going on for this tachycardia before you just pump into beta blockers. And anemia with beta blocker withdrawal is a bad thing. That's it. Thank you.